Welcome everyone to the November Liverpool Dementia and Aging Research Forum. Today we've got a really exciting talk by Dr. Stephanie Harrison. And Stephanie is a tenure track research fellow at the Liverpool Centre for Cardiovascular Science at the University of Liverpool. Her research interests include risk reduction and ways to improve health and quality of life for older people living with cardiovascular disease, dementia, and/or in care homes. So as always, you can also follow us on social media and have a chat there. So we're using the hashtag Liverpool Dementia if you are using social media. And also please feel free to post your questions throughout the talk and we will pick them up afterwards. So Stephanie's talk will last around 40 minutes approximately. And then afterwards we'll have a discussion about your questions and you can continue posing questions. So, without further waiting, over to you, Stephanie.
Thank you, Larissa. Okay, sorry, it just wasn't moving over to the next slide, but thank you very much again for the opportunity to present today and for the kind invitation and introduction. So as Clarissa mentioned, my name is Stephanie Harrison. I'm a researcher at the University of Liverpool. I work for a centre called the Liverpool Centre for Cardiovascular Science, which aims to improve cardiovascular, so heart health, in the region, nationally and internationally. And before working at the University of Liverpool, where I started about 2 years ago, I worked in Australia on a large data linkage project focusing on older adults living in care homes and also older adults accessing different types of aged care services, including at-home care services and respite as well. And since moving to Liverpool, I've continued to do research around big data and older adults living in care homes with more of a cardiovascular focus and also looking at stroke in older adults living in care homes too. So today I'm going to be giving an overview of some of the research we did in Australia using the Big Data project for older adults living in care homes, and then talk about some of my more recent research using UK big data sources for the similar topic. I'm going to give an overview about what we mean by big data and some of the strengths and weaknesses of this approach for health research, and I'm going to be talking about some of these different data sources, and I'm happy to answer any questions about either of the main studies I'm going to be talking about today, or about how we can better utilise big data in general for older adults living in care homes. So I'm just going to start by giving an overview about, I'm going to be talking about big data a lot. So what do we actually mean by the term big data? Well, there's no set amount for the number of participants or patients involved in a data set or the amount of data we're collecting. And the kind of definition for big data is evolving as it's becoming more frequently used for research purposes. So in 2016, in the British Medical Journal, it was described as where we aggregate and improve the accessibility of routinely collected healthcare and related records. And that's really the kind of definition that I want you to bear in mind, because that's what I'm going to be focusing on today. So we already have a lot of health data collected routinely and stored electronically. So every time someone has a GP visit, has a medication prescribed, has a hospital visit or different procedures, these are all captured electronically. And if we link together these different data sources, it can become a very valuable resource for research purposes. More recently, in the British Medical Journal, big data was referred to data sets which are too large or complex to analyse with traditional methods. So big data is large, and the more data sources you use, the more complex it gets, and we need to think more about our statistical approaches in how we best utilise all this data to answer our research questions. But the takeaway is what I'm really talking about is just linking together different electronic health records and using this for research. So why do we use big data for research? When can it be useful? As I've mentioned, it's using data that's already being routinely collected and linking it together. So if information is already being collected, which can be useful to answer some research questions, then it can save the time and also burden on the participants or patients in collecting the same data again. And often in clinical trials or different research studies, certain individuals are often excluded. And then if we use routinely collected data, it can give us more real-world evidence. So if certain individuals are excluded from different clinical trials, for instance, because of ethical reasons, because they aren't able to participate, then we can get an idea of the person's health or how a person is responding to treatment by using these big data approaches. And it can give us power for rare conditions, for looking at different subgroups, for instance, people, different age categories, or people with multiple conditions, which again might not often be included in standard clinical trials. And not to be confused with, it can be time consuming and it is time consuming to link all these data sources together and then access the data, but it does reduce the time collecting data. And if it's already being collected as part of usual care, then we shouldn't need to collect it again for research purposes. And some questions cannot be answered with a clinical trial. So we consider the kind of gold standard evidence for research to be a randomized control trial. So that's where we get a group of individuals and we randomize them to either receive a treatment or to not receive a treatment or to receive a different treatment. But not all research questions can be answered in this way. So just to give an example, so in the British Medical Journal every Christmas they publish articles on important topics in more light-hearted ways. So this article was published a few years ago to really highlight that not all research questions can and should be answered with a randomized controlled trial. So they use this example of if you wanted to look at the effectiveness of parachute use to prevent death and major trauma when jumping from an airplane. And they did a trial and randomized people to parachute use or an empty backpack. Obviously, people who use the empty backpacks jumped a much smaller distance from the airplane. So overall, they found no impact of parachute use on preventing death. But it's really just highlighting when people already know certain benefits of an intervention, it might impact how they interact with it. And also highlighting that even after we've done clinical trials, once interventions are used in a real world setting, we should continue to evaluate them, because once it's out of a controlled clinical environment, then there might be differences in how people use treatments or interventions compared to how it's done in clinical trials. So I've mentioned that routinely collected data can come from many places, including GP records, hospital records, medications prescribed. But if we link together these different data sets, we can build a better picture of a person's health. For instance, if we want to know the prevalence of a certain condition, it may not always be captured routinely in one data source, for instance, hospital records. But if we link with GP records and other health and social care records, we can build a much better picture of both the prevalence of conditions and outcomes for people. We can often link together data using key information such as people's NHS numbers and date of birth. And obviously we have to do this in a secure environment so that the linkage is done separately to the anonymised data we then use for research. And also some information which might be important for individuals' health may not be collected routinely. So it is possible that we can design a study where we collect primary data which isn't collected routinely, but then we go on to link to routinely collected data to see what happens to people over time. For instance, we might collect certain information about people And then we might be interested in how this impacts a person's hospitalizations over time. And rather than asking that individual about their experiences over a certain time, we could just link to their hospital records to do this remotely. So the first study I'm going to be describing is this Australian big data project I worked on and helped establish for people accessing different aged care services nationally in Australia. It was called the Registry of Senior Australians, or the ROSA project. And this project was quite timely because not long after it was established, there was a Royal Commission launched in Australia into aged care quality and safety. So Royal Commission is when the Australian government does a large-scale review of a service and makes and uses all the available evidence to make recommendations for how the services should be improved in the future. And this was launched because there was concerns about the quality of aged care nationally, and also differences between service providers in how the quality of care, so how well the quality of care was being provided to different individuals. So as I mentioned, big data can be useful for populations which are often excluded from different clinical trials and research studies, and older adults living in care homes, often not included in clinical trials, often have high prevalence of people living with dementia or cognitive impairment, often have multiple underlying health conditions, and moving to a care home is obviously a big event in someone's life and may not be the time that people want to become involved in research studies. But there's already a lot of data, as I mentioned, being collected about these individuals every time they use a different medical service or have a new diagnosis for a health condition. And that data can be useful to answer some research questions. So there've been a lot of smaller studies previously in Australia for about older adults living in care homes and accessing different types of aged care services, but they weren't necessarily representative of the underlying population. So with this registry, we're able to examine the health, the care and the healthcare utilisation of over 2 million people who use different aged care services nationally in Australia over around a 20-year period. It was a big collaborative project. So in the picture on the right is all our different partners, which included different academic institutions, clinicians, care providers, and we also had a large public and patient involvement group, including older people living with dementia. And that really helped shape our research questions and where our focus should be on when we started the registry. So one of the main questions that I looked at in this study was about the use of psychotropic medicines for older people living in care homes. So there was already a concern about the overuse of psychotropic medicines for older adults living in care homes. So this is referring to antipsychotic medicines, antidepressants, benzodiazepines, and guidelines state that for older people living with dementia experiencing what we refer to as behavioural changes, or often referred to clinically as behavioural and psychological symptoms of dementia, where people may experience symptoms such as distress, agitation, aggression. The first line approach should be non-pharmacological approaches such as therapies, and more medicine-based approaches should only be used if non-medicine approaches have failed or the person is at risk of harm to themselves or others. But despite these guidelines, we knew that there was a lot of psychotropic medicines being used for older adults living in care homes in response to behavioural changes for people living with dementia. And It was not really known, though, if they were already being prescribed these medicines before they entered a care home and it was just a continuation, or if these were being newly prescribed once people moved to a care home. So before we looked at this, we did a review looking at the evidence around different medicine-based approaches and non-pharmacological approaches for behavioural changes in dementia. And this is quite a busy figure, but all we really need to know is that the dotted line 0, if the blue dots are on the left-hand side, then that means that the approach is reducing the behavioural changes for the individuals, and if it's on the right-hand side, it's increasing, and if it's crossing the line, it's having no significant impact. So we compared what previous studies had shown about non-pharmacological approaches and medicine approaches for behavioural changes in dementia, and we can see that the effect sizes for the therapy-based approaches are quite similar to the medicine-based approaches, and actually music therapy was having the biggest effect size. But we also need to note that we did assess the quality of the evidence, and there was much lower quality of evidence for the therapy-based approaches and higher quality evidence for the medicine-based approaches. But even for a therapy called functional analysis-based intervention, which is where we try and identify the underlying reasons for the person's behaviour. So more and more evidence is showing that the reason for these behaviours is often nothing to do with the person's underlying dementia pathology, but is actually more likely due to unmet needs. So finding out the reason for the person's behaviour and coming up with a plan to help the person with that behaviour has a very similar effect size and moderate quality evidence compared to antipsychotics, which again have quite a small effect, similar effect size to functional analysis based therapy, but has a much higher risk of serious adverse effects and has been associated with higher rates of mortality and cerebrovascular disease for older adults living with dementia. We looked at these medicines before and after people moved to care homes to see if there was an increase in the use of these medicines once people moved to care homes. And the dotted line shows the time of entry to the residential care home, and the dark blue line is for antipsychotic medications, and we can see once people are moved into care home, the proportion of people being prescribed the medicines does increase and then does not decrease over time. So this is showing the first year after moving to a care home. And we see a similar pattern for antidepressant medicines, so a high proportion of people are being prescribed these, and it rises steeply after moving to a care home and continues to rise in the year following care home entry. And for benzodiazepines, there is again a steep increase, but it does decrease after the first 3 months, but not to a level of before moving to a care home. So there's indication here that the prescribing of the medicines may not always be appropriate, as again, guidelines state that non-pharmacological approaches should be the first line therapy. We don't have the granular level of evidence to see if those therapeutic approaches were trialled before the use of the medicines, but given the high proportion of people receiving the medicines after moving to a care home compared to what the rates were before moving to a care home, then it does indicate that this is something that needs to be addressed. When we looked at whether the people had a diagnosis of dementia for antipsychotic medicines, we can see for people living with dementia after moving to a care home, the proportion of people receiving antipsychotic medicines in the first year after moving to a care home rose to about 1 in 3 people receiving an antipsychotic medicine at some point in the first year after moving to a care home. And as I said, the guidelines state these should only really be prescribed when the person is at an immediate risk of harm to themselves or others. And so we've shown this, but was anyone kind of interested, and how can this help impact services for older adults living in care homes? So as I said, this registry was quite timely, because at the same time there was a Royal Commission going on into aged care quality and safety, and we were able, as well as academic publications, to produce reports for this Royal Commission. And it resulted in their interim report. They had 3 key recommendations where they thought urgent action was needed. And one of those was to respond to the significant over-reliance on chemical restraints in aged care. So chemical restraints is referring to using these psychotropic medicines more for their sedative properties rather than as intended. And they also gave recommendations into providing more home care services, as there was a long waiting list. And you can see a publication we did here, which we also provided to the Royal Commission, showed that people who were waiting for home care packages were actually at a high risk of dying before they received the home care packages, or moving to a care home before they received the home care packages offered by the government. And another recommendation was about the flow of younger people moving into aged care. And again, because of this big data resource we had, we were able to look at the numbers of young people moving into care homes. So this is people aged under 65 who need help and need to be in a long-term care environment, but there isn't an appropriate service for them. And so they are offered to move to a care home for older people, which may not be the most appropriate place. So when we do these kind of big data studies, which capture a whole population, kind of shown here that policymakers are interested, because you can't really argue with data when it is capturing a whole population, and it can help identify areas in need of improvement. This resulted in recommendations to improve care, which was backed up by substantial funding, and we're able to continue this project going forward to see whether these recommendations will result in impact and help to reduce the number of people being prescribed, for instance, these psychotropic medicines. Okay, so another question we were interested in looking at with this Australian registry was about the use of respite care and whether it impacts entry to a long-term care home. So residential respite care is short-term care provided when a carer or care recipient requires a break from their usual care arrangements. So we know that informal carers are extremely valuable in supporting people to stay living at home, and respite services are meant to support them. But the idea is once the carer is back, the person will return home. They are meant to be short-term care instances, not a long-term care solution. And in Australia, people can apply for respite care, and if approved, they can access up to 63 days per year. And there's about 75,000 people who use respite care annually, at an annual cost of around 300 million Australian dollars to the government. And despite this high cost and high usage, there was no real evidence of whether respite care was helping carers or helping people to stay living at home longer. So we looked at we were able to look at over 480,000 people who were approved for respite care. And this just shows some of their characteristics. The mean age was 83, about 60% were female. A quarter of people were approved when they were in hospital, 28% had a diagnosis of dementia recorded, but only 37% of these individuals who were approved actually went on to use respite care. We looked at those individuals, around 177,500 people, and found that of all these individuals who actually used their approval, A third were using respite and not returning home afterwards. They were moving straight into a long-term care home place. 41% were using respite and not moving straight into long-term care, and only 27% actually used their respite approval 2 or more times. So we wanted to look at whether this use of respite services was helping to delay people moving to a care home, which is kind of one of the goals of the respite services being offered. So we looked at the different ways people use respite care compared to people who didn't use respite, to see how many overall number of days they spent in residential care. So that was combining their respite days and their long-term care home days. And we found that for people who used respite and did not go directly to a long-term care home, they had a reduced number of days spent in a residential care home compared to people who didn't use respite. But when people use respite once and moved directly to a care home, they actually had more days, and this was taking into account different characteristics such as age, sex, country of birth, whether the person had a carer, their health conditions, and activity limitations. And speaking to different care providers, the reasons why people might use respite once and not return home afterwards is because they might be using respite as a sort of trial to see if they are okay living in a care home. They might be using it while they're waiting for a permanent place to become available. And it's not to say these reasons aren't valid and shouldn't be allowed, but it's not respite. So people using it for those purposes might mean that people who do want to access respite care are not able to, as we know there's a high demand and places not always available. And we've shown that only 37% of people approved actually did go on to use respite care. So maybe we need to offer more diverse range of services so people are only using the actual respite care as intended, rather than using respite as a way to see whether they are okay to move into a long-term care home place. So I've talked about this registry in Australia, but what big data sources are available for health research in the UK? Well, there's a lot of specific disease registries if we're interested in a certain condition, such as for cancer, there's a large National Cancer Registration and Analysis Service. There's lots of different audits conducted in hospital. As I've mentioned, there's a lot of data collected on when people had a hospital visit, procedures they had, and also primary care data, so GP data, social care data, data about mental health services use. But in silos, this data can have limited use, and if we link together the data sources, it can improve usability. So NHS Digital and the Office for National Statistics hold a lot of data about hospital use, so hospital episodes and mortality, and different data sets have been put together to link different information held at NHS Digital with other different data sources, but not necessarily have they then been able to identify older adults living in care homes. But one that has is in Wales. There is a project called the SAIL Data Bank, which stands for Secure Anonymised Information Linkage, where they have linked together GP records, secondary care records, mortality information, medication prescription, and much more. And what they did is develop an algorithm to link people's address data with address data from about care home addresses in Wales to determine the dates people moved in and out of care homes. So I'm going to be talking about that a bit now, and specifically focusing on some of the research we've done with the SAIL Data Bank recently. So within the SAIL Data Bank, there's a lot of different data sources linked together, including information about people's demographics, their hospital use, and their primary care data. As I mentioned, they've been able to identify when people move in and out of a care home by linking to care home addresses held by the Care Inspectorate in Wales. So overall, they've been able to create this anonymised data set, but determine when individuals move in and out of care homes. So one of the projects we've been working on with the SAIL data bank is to look at stroke and atrial fibrillation in older care home residents in Wales. So atrial fibrillation is a common irregular heart rhythm which increases a person's risk of stroke 5-fold. And both stroke and AF are important for the older population as they increase in prevalence with age. So we first started by doing a review about atrial fibrillation in older care home residents to see what information was already available. We found 21 studies which reported that atrial fibrillation was prevalent they ranged from 7 to 38% of older individuals living in care home. But overall, there was quite limited data about stroke and atrial fibrillation in older people living in care homes. And what was particularly important is primary and secondary stroke prevention strategies. So for instance, people with atrial fibrillation are at higher risk of stroke, so they usually should be prescribed medicines to help reduce their risk. And these are known as oral anticoagulants. And anticoagulants do help reduce a person's risk of stroke, but they do carry a marginal increased risk of bleeding, so people should be monitored appropriately. But usually the potential benefits of reducing risk of stroke for people with atrial fibrillation with anticoagulants usually outweighs the potential for the increased risk of bleeding. And instead of withholding anticoagulants for people who may have a higher risk of bleeding anyway, they should just be monitored more appropriately. So we looked at atrial fibrillation in older care home residents in Wales. So there are about 14,500 people aged 65 and over with atrial fibrillation over about a 15-year period who moved into care homes in Wales with a diagnosis of atrial fibrillation. Their median age was 87 and 65% were female. And we looked at how these oral anticoagulants I talked about were being prescribed. So we found that only 1 in 2 people with atrial fibrillation were receiving oral anticoagulants. And we looked at the factors which might be impacting the prescription of oral anticoagulants and found that people who are not being prescribed them were more likely to be of a higher age and to instead be prescribed antiplatelets, which are not the guideline recommended way of reducing a person's risk of stroke when they have atrial fibrillation. Oral anticoagulants are preferred or recommended. But we did find that those who were being prescribed oral anticoagulants were the people who had the most stroke risk factors. So they had other cardiovascular conditions which were putting them at a higher risk of stroke. And also people living with frailty were also more likely to be prescribed oral anticoagulants, which is a good sign because previous research has shown that perhaps frailty may be a reason why people aren't being prescribed oral anticoagulants, but it's not what we found in this study. But overall, there was quite a low prescribing rates for oral anticoagulants in this population, indicating that stroke prevention may not be optimized. Okay, so then we went on to look at stroke specifically for older adults living in care homes. And we just started with describing how many people were moving into a care home with a recent stroke, so stroke within 12 months of moving to a care home. And we can see between 2003 and 2018, there wasn't much change in the proportion of people. Around between 5 and 7% of individuals moving to a care home had a recent stroke. But we found that the time between stroke and care home entry was decreasing. So from a median number of days between stroke and care home entry of 135 days, actually reduced to 95 days, which may indicate that people who are moving to a care home with a recent stroke have had a stroke more recently and may have a higher levels of disability from that stroke. We then looked at strokes people experience after moving to a care home and found that people who'd had a previous stroke had a much higher incidence of stroke after moving to a care home compared to people having a first-time stroke. But overall, the 30-day mortality after experiencing a stroke in care homes was very high, at nearly 50% of people who experienced a stroke in care homes dying within 30 days. And people who'd had a previous stroke before this were at higher risk of both having another stroke and also dying once they had a stroke within a care home. So devastating impact of experiencing a stroke for older care home residents. So we looked at, for people who moved into a care home with a recent stroke, what secondary stroke prevention treatments they were receiving. So with guidelines, people who had who have a previous stroke should be prescribed antiplatelets and often statins, but only 61% of people being prescribed antiplatelets and only 50% being prescribed statins. For people with previous stroke and atrial fibrillation, those oral anticoagulants, again, were only being prescribed in around 60% of the individuals. But for people with previous stroke and hypertension, they should be being prescribed antihypertensives, and about 92% of people were, so showing more promising that antihypertensives were being prescribed for these individuals. So it is complicated about prescriptions in these individuals, because we know that polypharmacy, so being prescribed 5 or more medicines, or hyperpolypharmacy, being prescribed 10 or more medicines for older care home residents or people living with dementia, can have negative impacts. And as people move towards the end of life, there has been an increased evidence base that we should be looking to deprescribe medicines which aren't adding a quality or quantity of life. However, for stroke prevention, especially, we can see that people who've already experienced a stroke have a much higher risk of another stroke, and if they do have another stroke, a very high risk of dying with that stroke. And we should be making sure that their stroke prevention is being optimised. But again, because these individuals aren't often included in clinical trials, it can make clinical decision making quite difficult. So knowing which medicines should be prescribed, what are the optimal stroke prevention pathways in this population. So there's a real need for further research in this area to balance out how we know when to deprescribe certain medicines in this population, and how, whilst bearing in mind that we're optimally making sure that we are preventing stroke as much as possible. So I've mentioned a few big data sources for older adults living in care homes in the UK, but is there a need for more? Well, the COVID pandemic has highlighted the general need for more research for older care home residents. It's a sector lacking sufficient recognition and resources. As I mentioned a few times, these individuals are often excluded from research studies and clinical trials. But there's a lot of data being collected on this population, which isn't often linked or easy to access for research purposes. So if we had better resources in this area, then we may be able to better utilise all this data that's already being collected to answer some important research questions and increase the representativeness of these individuals in research, improve knowledge, and most importantly, optimise care pathways to improve health and social outcomes, including quality of life. As I mentioned, some data which is important, some information which is important for all the care home residents isn't captured routinely. For instance, when we've had public and patient involvement groups before, some key outcomes of interest are things like fatigue, loneliness. These aren't always captured routinely, and perhaps there's a case for trying to capture some of these important outcomes better routinely, so then we can then link to what is being captured. And there is a potential for some data sets which have been established during the pandemic to be continued to be used to improve future research beyond the pandemic. So just to give a quick example, during the pandemic, the Cheshire and Merseyside Combined Intelligence for Population Health Action, or CIPHER project, was established as part of the COVID response. So they linked together a lot of important health data sets for populations in Cheshire and Merseyside. And it's still being used for COVID research, but there is potential to use these data sets beyond the pandemic to answer health research questions more generally. And we can draw on what's been done, for instance, in the Welsh data set to try and see if we can identify older care home residents, so we can build more big data projects for this population. So I think I've mentioned some of the limitations of using big data generally and for care home research, but we just have to bear in mind when we're interpreting results that the data was collected routinely as part of people's healthcare. It wasn't designed to answer our specific research questions, so there will always be limitations that we have to bear in mind. We have to think whether what we're interested in was captured in the population well or not, and if not, how we can improve this potentially by linking in different data sources. We do need identifiers to link different data sets together, and we need to make sure we're doing this securely before anonymisation. Once these data sets are established, there is a high demand for them, costs involved, time in establishing them, particularly at the beginning. But once established, an appropriate approvals process is in place, and then they can be used for many different research projects. So overall, I think big data can be a powerful resource to answer some important research questions about older people living in care homes. This is particularly important because older people are often excluded from certain clinical studies, but it's important to note the strengths and weaknesses of big data when we're talking about linkage of routinely collected data, and that if we're recognising these limitations and only using the data sources to answer questions which can be answered with the appropriate data sources, then I think they still can be a valuable resource. And I've given some examples of available and emerging data sources in the UK for care home research, and I think from the pandemic, a positive may be that we see increased efforts into linking together different data sources, not only to help in future research around COVID, but also beyond this to answer different important questions for health for older adults living in care homes. Okay, thank you.
Thank you so much, Stephanie. That was really interesting, and lots of different research you've presented as well. That's great. You've been busy. That's fantastic. So we've got quite a few questions in the Q&A. Please feel free to continue posting your questions. First of all, thank you so much, Steph. That was really good and nice to hear about the SAIL data bank again as well, having done some research with them as well. Maybe I kick us off with a question. So you presented a few different research streams there that you've done, all interlinked with the big data, and what particularly interested me when you talked about the psychotropic use increase after care home entry. So working with care homes and care home residents as well, and noticing obviously increased behavioral difficulties, also considering that particularly when we look at people living with dementia, it's mostly people with dementia in the advanced stages entering a care home as opposed to one of the mild stages. But it was interesting to see that suddenly that use of medication just increased. Is that possibly because there might be easier access to the medication there? Is it maybe increased behaviors? Or one thing I thought about as well, is it maybe that people living with dementia are maybe not better cared for at home, but receive more care at home, so they don't need the medication, if that makes sense?
Yeah,
What are your thoughts?
I agree. I think there'll be different reasons, but one reason might be that when people move to a care home, they may become distressed. And because they're not surrounded by the individuals they have at home, because the staff are new to them and they might not know whether the behaviours are normal for that individual, or again, mention the underlying reasons for these behaviours are often unmet needs. So they may not be having their needs addressed as quickly as they would at home, and they're responding to this by having different behaviours, which might just be distress. And the Australian government uses this term of chemical restraints, which is kind of on the side of people being prescribed these medicines as just to calm them down in a way, rather than looking. The preferred approaches and what should be as a first line approach is firstly just to try and find out the reasons for that behaviour and then help the individual. And there might not be the time for that in a care home always, or the resources or the experienced therapists that might be needed to help people with these behaviours. So it probably is a mix, but it's probably likely due to a lack of experience or resources, people not knowing how to respond to behaviours, and a sort of, is sometimes referred to in literature as a culture, so a culture of prescribing. So when these behaviours happen, even though clinical guidelines state that first line approaches shouldn't be medicines, a culture of prescribing in terms of, okay, this person's experiencing this behaviour, for that what we do is we ask the GP to prescribe an antipsychotic or an antidepressant to help them, and they think that is the best way of helping them, even though we know from the evidence that should only be used in the most extreme cases. So I think there is probably room to do some more qualitative work. I mean, it's just kind of speaking to people anecdotally about the potential reasons for this, and there has been qualitative work done. But rather than always knowing the underlying reasons why this is happening, thinking about what we can do to reduce the use in the future. So if it is that people are becoming more distressed after moving to a care home, and we can see that 3 months after moving to care home seems to be such a crucial time to where we see the biggest increase in the use of these medicines. How can we better support residents when they're moving to a care home? How can we better support staff to cope with these behaviours, rather than automatically thinking that we need to prescribe medicines? Absolutely,
it's all about trying to focus on non-pharmacological, but also, I suppose, speaking to staff and speaking to carers a lot. It's about providing good quality training to care home staff to recognise that can be dealt with without medication.
Definitely, there's all these different therapies available, but if people aren't aware of how to use them, then it's just not going to happen. And there's a lot of push to de-prescribe medicines for older adults with dementia or living in care homes, but rather than always focusing on de-prescribing, maybe if they weren't prescribed in the first place, then we wouldn't need to think about how we de-prescribe without the withdrawal effects. If we focus more on how we can support staff and residents so they're not needed in the first place, then we might not need as much focus on de-prescribing these medicines.
Yeah, and you've briefly picked up on that, but there's been a question from Jackie about, are medicines prescribed by care homes or by the attached GP, and should they be lobbied to stop the practice? The latter part of which you kind of just answered, but what's the situation in Australia?
So I think a lot of the research that's been done around de-prescribing these medicines is that you can't just target a specific group like GPs, or it is kind of a mix of, there'll be the nurses in the care homes, pharmacists who do medication review, who are meant to do medication reviews quite regularly, but again, we've done research into that showing that they're not done as regularly as maybe we'd like them to be, and GPs. And really, to get these medicines not being prescribed as much, you need to involve the whole team as well, because if the people who are there helping the residents day to day, if they're not able to cope, then they will be more likely to reach out to the GP or pharmacist and say, I need an antipsychotic for this individual because we don't know how to cope with their behaviours. So, as I mentioned before, this kind of culture of prescribing, you need to involve all the staff to make a change in order to reduce the amount of prescribing of these medicines.
Yeah, and here a little sharing story from Joan, who's a carer. My father was put on psychotropic medicine in a care home due to unmet needs, due to not enough staff in the care home to meet his needs. And she raised this issue and she was ignored, and carers didn't seem to be trained in dementia and didn't have general management skills of behavioural changes, just kind of what we discussed. So thanks for sharing that, Joan.
And I think we will see variability. So something we're doing in Australia is kind of setting up a sort of, they call it like a monitoring system, but it's more for the individual care homes to see how well they're performing compared to other care homes. And one of the outcomes is about the prescribing of antipsychotic medicines, so they can see their kind of rate of prescribing within their care home, while taking into account different resident characteristics compared to others. And then it'd help identify the actual individual care homes who might have more of this prescribing culture compared to others who may have more resources devoted to staff training to help with behavioural changes for people with dementia.
There's a slightly different yet related question from someone here as well on whether there are any data to show differences in the dementia subtype and who the medication was prescribed to. So this person specifically relating to Lewy body dementia as an example. Yeah,
so we can look at different subtypes. There is coding for different subtypes of dementia within routinely collected data, but I'd say it's not always coded very well. And especially as people get older, their underlying pathology, so Alzheimer's and vascular dementia, they can sometimes have mixed pathology, making it more difficult to code these. So I think we can look at different types of dementia, and there are codes for like Lewy body dementia. But I think that there's also codes for just other dementia where it's not coded very well. So we could potentially do a study where we look at all the people who have a code for Lewy body dementia, but we might not be capturing everyone because they might have been coded as a different type of dementia. So often we'll stick to kind of using the whole umbrella term for dementia, and sometimes we will look by different subgroups. But the power of big data is that we do normally have the numbers, so that we could do studies just looking at people with Lewy body dementia and still probably have quite a large cohort compared to if we did a primary data study for people with Lewy body.
And would you be able to do that with UK data or more Australian data, do you think?
You can do with either. The coding is there's an international coding systems for hospital records, and for GP records there'll be different codes for different types of dementia. We just have to kind of bear in mind the limitations of when we're trying to look more specifically. It's the same with other conditions where there's different types. If we just use a kind of the umbrella overall, the kind of top level of coding, then we're more likely to capture the individuals. When we start to break it down, then there can be more room for error in which codes are used. So we just have to bear that in mind, but it is possible.
And I'm mindful there's a couple more questions here, maybe just the last one. To you, Stephanie, would it be possible to do a similar big data analysis of care home entry and antipsychotic use in people with dementia in the UK? So what you've done in Australia to kind of replicate that here, or has it maybe been done already?
Not as far as I'm aware. There was a national study done about the use of antipsychotics in the UK a few years ago, but it wasn't specifically looking at the whole before and after care home entry. It just kind of showed overall 1 in 5 people being prescribed antipsychotic medicines in the UK, which is very similar to the numbers we were seeing in Australia. So we could potentially do that in a resource like the SAIL data bank. But for England, as far as I'm aware, that kind of big data project the resources aren't available there at the moment. But as I say, I think moving forward after the pandemic, because there's been an increase in data linkage, then hopefully we'll see more resources for England. And we did actually do a study using a kind of a big data project in the US, looking at the use of psychotropic medicines during COVID, and we actually found unfortunately an increase in, not specifically for people with care homes, but people living with dementia. We did find an increase in the use of these medicines during the pandemic, which brings into questions of why, perhaps, as we know, during the pandemic, people living in care homes weren't allowed visitors or had very significant restrictions, and care homes having to cope with potential COVID cases and all the everything they had to cope with may have led to an increase in the use of these medicines again. So again, we showed that in the US there was an increase in these medicines overall for people living with dementia. Whether that's the case specifically for people living in care homes, we're not sure yet, but I think that'll be an area of interest for the future, because I could hypothesize that because of all the restrictions people had living in care homes during the pandemic, they might have increased the rate of behavioural changes, and then unfortunately lead to an increase in the use of psychotropic medicines.
Yeah, we found that in our qualitative investigation looking into care homes and the impact of not seeing their loved ones at all, so complete deterioration of mental health and dementia symptoms. So but this is all we've got time for. I'm having a look at the time. So thank you so much, Stephanie. That's been really interesting, and thank you everyone for posting your questions as well. And if people would like to get in touch with you, they can drop you an email, Stephanie?
Yes, of course. So it's just stephanie.harrison at liverpool.ac.uk. So yeah, thank you again, Clarissa. Do you want me to put the next slide about your next?
Yes, please. So just introducing our next webinar, and yes, we'll still stay virtual. So for the first webinar in January, on the 26th, again from 1 to 2 o'clock, we will have Dr. Ada Suarez Gonzalez from UCL. She's a neuropsychologist and researcher, and she's also involved with Rare Dementia Support Group. So some of you may or may not be familiar with that already, but she will be giving a talk about rare dementia treatment and support, which can include Lewy body dementia, frontotemporal dementia, and lots of other rarer types. So I have posted the link in the chat box, but you also see it in front of you on the screen. But yes, thank you everyone. Thanks again, Stephanie. And you can also rewatch this recording on YouTube afterwards. Thank you, everyone. Bye.